This video has been funded through an education grant by Sanofi Limited. Sanofi has had no input towards the content of the video or the interviews. Cold agglutinin disease is a rare condition affecting between 5 and 20 people per million. As a complement-dependent disorder, it shares many of the hallmarks of an autoimmune condition, but brings with it its own challenges. Professor Sigbjorn Berentsen of Haugesund Hospital in Norway spoke with us about the biological underpinnings of cold agglutinin disease and how that translates into patients' symptoms.
Cold agglutinin disease is a chronic form of autoimmune hemolytic anemia, and autoimmune hemolytic anemia is anemia, low levels of hemoglobin in the blood, caused by destruction of the red blood cells by autoantibody to the red blood cells. Autoantibodies are antibodies to one's own cells. The autoantibodies in cold agglutinin disease are called cold agglutinins, which means that they can agglutinate, that is, clump together, red blood cells. Cold agglutinins can bind to red blood cells at temperatures between normal central body temperature, and it's important to know that such temperatures do not occur only in cold environment, but also occur normally in exposed parts of the body, for example, the face, the arms, the feet, and so on. They will also bind a substance called complement, which is a somewhat complex part of the immune system. Cold agglutinins and cold agglutinin disease are produced by so-called B lymphocytes or B cells in the bone marrow. Normal B cells are cells parts of the normal immune system, but clonal B cells are slightly abnormal in that all of the clonal cells are alike. They have identical properties, and they are produced. They all descend from one single cell. This slide shows how it will appear for the pathologists when looking in the microscope. And I have tried to mark groups of clonal B cells within the bone marrow. And when I said that there were abnormal cells in the bone marrow, some people will ask, is this disease a cancer? Is it a malignant disease? And the answer is that it is not. The abnormal cells do not go outside the bone marrow, and transformation, change to a malignant disease is very rare in cold agglutinin disease. And cold agglutinins bind to the red blood cells, and the red blood cells will agglutinate, that is, clump together. And that agglutination or clumping is not the same as formation of a blood clot. This process will lead to a hemolytic anemia. Red blood cells will be destroyed, and I will come back to how that will happen. And also, the agglutinates, the small clumps of red blood cells, will have problems in the passage of the smallest blood vessels, the capillaries. So there can be what we call circulatory symptoms, a bluish discoloration of the nose and face and fingers and feet, in particular in the cold, and also what we call Raynaud-like symptoms. And for example, patients may have difficulties in taking food from the fridge, and they in general don't tolerate cold temperatures.
How do you reach a CAD diagnosis?
It is necessary to confirm that the patient has hemolytic anemia, which is confirmed by a relatively simple blood test. Then you need the DAT, or so-called direct COMS, to diagnose an autoimmune mechanism, to see if the hemolysis is due to an autoimmune disease. And if you confirm that, you also need further, more specific tests to confirm the type of autoimmune hemolysis. And after that, you need to do a cold agglutinin titer to detect cold agglutinins in the blood and determine the quantity. Many patients have detected before they see the specialist that cooling is not good. They notice those symptoms and they notice reduced tolerance to cold environments, and they have detected some of these points themselves. But what patients should be explained is that avoidance of cooling is good not only to avoid the circulatory symptoms, the bluish discoloration, etc., but also to reduce the danger of severe hemolysis. I try to educate patients about avoiding cooling, and especially of avoiding cooling of the extremities and face. But it's even important to educate healthcare personnel, because when patients are in a hospital or in an outpatient department, they should not be exposed to low temperatures. And for example, infusions should not be cold. So that's important too. About 1/4 of the patients with cold agglutinin disease have severe anemia, if we define severe as a hemoglobin level between 8 grams per deciliter or 80 grams per liter, as it also is called. 1/3 or somewhat more have a moderate hemolytic anemia, a hemoglobin level between 8 and 10 grams per deciliter. About 1/4 have a mild anemia, an anemia with a hemoglobin level more than 10, and a small minority, about 10 or 12%, have what we in medical terms call compensated hemolysis. That is, they have hemolysis, but they have not anemia because the bone marrow is able to compensate by producing more red blood cells. So what should trigger treatment in terms of hemolytic anemia? There is no definite trigger, but I think all patients with severe or moderate hemolytic anemia should be treated, and some patients with mild hemolytic anemia dependent on additional symptoms. Additional symptoms may, for example, be fatigue, which is caused not only by the anemia by itself, but also by activation of the complement system. Patients with disabling cold-induced symptoms from the circulation, for example, those who can't take food from the fridge, and other patients in whom the circulatory symptoms affects daily living, should also be offered treatment. So that's the best answer I can give on whom should be treated. I think today about 80% of patients with cold agglutinin disease will need treatment. So in old literature, it was often said that most patients should not be treated, but that's not true today.
What treatment options are there?
Treatment can be directed at targeting the abnormal B cell clone or the complement system. And the B cell clone can be targeted by monotherapy with a drug called rituximab, that is an artificially produced antibody against the B cells. And we can use rituximab as monotherapy. The advantage by doing that is that it is tolerated by most patients. Severe side effects are relatively rare, but the drawbacks are that it's not very efficient. It often improves the disease for a short time, often some months, up to 1 year. And it is often not very efficient. So we can combine the rituximab with cytotoxic drugs, for example, bendamustine. That's far more efficient. and produces much more durable improvements of the disease, but there are more side effects. Then we can also use a drug called bortezomib, and we can also use a newer drug called ibrutinib to target the B cells. Alternatively, as I already said, we can try to target the complement activation by using a complement inhibitor, a drug that blocks complement activation. That drug is called sutimlimab and has to be given as an intravenous infusion every second week. The advantages of sutimlimab is that it is very efficacious against the hemolytic anemia. Patients often achieve a normal hemoglobin level very rapidly. The drawbacks with sutimlimab is first that it is extremely expensive, not available in all countries, and in some countries not available for all patients. Also, sutimlimab will not improve the cold-induced circulatory symptoms, the bluish discoloration and the Raynaud-like symptoms in the cold will not be alleviated by sutimlimab. So the patients will still experience those symptoms from the circulation. In countries with a well-functional specialized hematology service, wrong medical treatment should not be very frequent. But on a worldwide basis, it is. The most widespread wrong treatment is treatment with corticosteroids, prednisone and prednisolone and so on. It doesn't work in cold agglutinin disease. It's often used by some doctors because it works in other types of autoimmune hemolytic anemia, but it should not be used in cold agglutinin disease. So that's an example of wrong medical treatment.
How are trials changing access to new treatments?
Patient contribution will be preferred when planning trials. So, for example, in the US, the CAD Foundation might be consulted when planning clinical trials, and I think input from the patients will be important because they know how they perceive the disease and what are the unmet needs. We don't still have the ideal treatment for cold agglutinin disease. We are much better off than 10 years ago and very much better off than 20 years ago, but we haven't yet the ideal treatment. So clinical trials are important, and I would encourage patients to participate in clinical trials.
Do other health complications, such as infections, pose a different risk to those with CAD than without?
Yes, it's important, and that is because infection, and in particular infection with fever, can trigger exacerbations, worsenings, acute worsenings of cold agglutinin disease. So patients can get more anemic, destroy more red blood cells. And therefore, patients should be aware that if they get fever, they should see the doctor, and the infection should be diagnosed. And of course, it's not possible to treat all infections. For example, in most viral infections, there is no treatment, but bacterial infections can be treated, and prompt treatment of bacterial infections is important to avoid exacerbations, worsenings of cold agglutinin disease of the hemolytic anemia. Of course, there are some consequences. I think, after all, the most important consequences are the consequences of anemia by itself. Patients do not feel well. They are fatigued. They have fatigued also because of the complement activation by itself. In particular, if the patient has severe anemia and need transfusions, there may be a danger of iron overload in the long run. that danger is not very big, but it is there for some patients who need transfusions. And the best way to avoid that risk is to treat the patients for cold agglutinin disease. And patients with cold agglutinin disease also have some risk of thrombosis, of formation of blood clots in the veins or in the lungs. That risk is not very high in the chronic phase of the disease. It may be higher during acute worsenings of the disease. So in some situations, patients may need drugs to avoid thrombosis, but in the chronic phase, most patients do not need such drugs.
What are your final thoughts on CAD and its care?
One of the misconceptions is that the disease is only related to cold environments. It isn't. It's named cold agglutinin disease because the autoantibodies are most active below normal central body temperatures, but the disease is not only related to cold environments. In patients with cold agglutinin disease, the disease is there all the time, whether it is warm and cold around you. Another misconception is that patients should usually not be treated. I would say the opposite. Patients should usually be treated. Some patients do not need treatment with very mild disease, but most patients will need to be treated. But if a general practitioner has a particular patient with cold agglutinin disease, of course, he or she should educate himself. Then, at the specialist level, patients with cold agglutinin disease should be seen by a hematologist. They should undergo a sufficient diagnostic workup. And if the hematologist is not familiar with cold agglutinin disease, he or she should refer the patient to a hematologist who is. As I said, some patients with cold agglutinin disease do not need treatment, but most patients should be treated, and treatment should be tailored according to the profile of the symptoms of the patient, and also patients should be asked for their preferences.